Hello everyone, welcome to Care Team Development and Optimization. This is one of 4 learning modules available to you on the portal addressing the topics of care teams. My name is Sarah Kerr. I have over 10 years experience in nonprofit community clinics, including health center management, quality improvement, service delivery, and practice redesign. I'm currently the site administrator at Humboldt Open Door Clinic, and prior to that served as Director of Patient Services at Six Rivers Planned Parenthood. I really look forward to spending the next hour with you, talking about care team development and optimization. Before we jump in, I'd like to quickly review our learning objectives for this module. By the end of today's webinar, participants will be able to describe the key functions and components of care teams. Participants will be able to understand how care teams can enhance a practice's ability to move through patient-centered health home transformation. They'll be able to understand the cornerstone concepts of care team optimization, as well as describe and implement key strategies to effectively redesign care team roles in your practice. And participants will be able to recognize and cope with common challenges of team culture. The dictionary defines a team as a number of persons associated together in work or activity. We can find teams in almost any setting, from the business office, to the classroom, to the sports arena, and even in our own homes. The fundamental purpose of any team is to achieve an agreed-upon outcome through collaboration in the vision of labor. Let's take a simple example of a baseball team. The team's agreed-upon goal is to score more points than the opposing team to win the game. In order to do so, each person on the team has to play a designated role, which has specific tasks and duties assigned. The pitcher has to throw the ball past the batter without them hitting it. The outfielders need to intercept the ball to hit in their direction. And the coach needs to oversee the entire operation to provide guidance and support to all the members. The team can only achieve their desired outcome by working together. So how does this rather simplistic example of a sports team translate to the complicated world of healthcare? Teams are everywhere in healthcare. The surgeon, operating room tech, operating room nurse, and anesthesiologist in the operating room are a team. The oncologist, radiologist, and surgeon treating a cancer patient are a team. The physician, medical assistant, and receptionist in a small family practice office are a team. Teams seem to work well in specialized facilities because the workflow tends to be more standardized. Thus, places like dental offices with dentists, dental assistants, and dental hygienists often function smoothly, with each person trained to perform a relatively limited set of tasks. Similarly, offices of ophthalmologists often are well organized, with the medical assistant checking visual acuity and visual fields, the ophthalmologist doing retinal exams, diagnosis and treatment, and the optometrist prescribing lenses, while the optician creates glasses. Primary care is a whole different ball of wax. A busy primary care office handles such a wide array of patients that it's difficult to routinize what happens each and every day. One elderly patient with 6 diagnoses, 11 medications, and a cognitive dysfunction can disorganize a primary care clinic for a whole morning. A child having an acute asthma attack or an adult with new onset chest pain can rearrange the entire afternoon schedule. With hundreds of diagnoses and the need to provide acute, chronic, and preventative care services, organizing primary care can be a major challenge. That said, it's a challenge that primary care practices across the nation are rising to, and despite the difficulties, care team development and optimization is something that we can all achieve with some basic building blocks. A team is the sum of its parts, so let's start by examining membership of a care team. Teams can be designed in a variety of ways depending on the size and needs of the patient population and the resources of the practice. Ideally, primary care practices should be structured to respond to all common problems for which their patients seek care. And since patient populations can vary substantially in age, gender, illness patterns, and social circumstances, the composition of primary care teams must also vary. For instance, social issues may be more prevalent in some practices than others, indicating the need for a social worker to be an everyday care team member. However, there are some general principles that we can apply broadly. Most successful practices are organized around an accountable clinician and a medical assistant dyad who interact continuously throughout the day. The medical assistant is generally responsible for preparing the visit, checking in and rooming the patient, and ensuring post-visit tasks are completed and patients understand follow-up plans. Other team members are usually responsible for providing self-management support, people like nurses or clinical pharmacists or health educators. They may also arrange resources and do ancillary tasks. Tom Bodenheimer, a primary care doctor who works at the University of California, San Francisco, uses what he calls teamlet, made up of a provider and a nurse or a medical assistant who's specifically trained to coach patients to manage their illness and to reach out to patients who need to come in for chronic or preventative care. The goal is that this two-person team is able to address most routine primary care needs when structured and trained properly. Some organizations include clinical pharmacists or nurse case managers on their teams in a 1-to-4 ratio. So that's 1 pharmacist or nurse for every 4 provider panels. But regardless of team composition, care has to be taken to keep the team size relatively small, fewer than 5 to 7 members ideally, because team functioning breaks down as teams get too large. Other clinic staff members, including billing staff, receptionists, computer techs, laboratory personnel, they all complement the primary care teams. Each of these staff members can play an important role in engendering strong, trusting relationships between patients and their care team. For instance, receptionists can help ensure that patients see the chosen team, reach out to them when follow-up is needed, and remind them to bring in medications. Everyone plays a role. Amazingly, the most frequently forgotten member of the care team is the patient. The patient should always remain the center point of the care team and be actively engaged in his or her own care. Now you have a collection of team members with defined roles, but they need an agreed-upon outcome to work toward. Perhaps it seems obvious to you what the goal of a care team should be, but this is an important discussion to have within your own practice. Team members need to all understand the goals in order to work collaboratively to achieve them. Ideally, the practice should come up with goals in a collaborative setting to maximize engagement of staff and set a clear vision for the work ahead. So, how do care teams fit into the bigger picture? How will development of a care team assist a practice in becoming a patient-centered health home? Care team development and optimization are action steps within the concept of continuous and team-based healing relationships. Continuous and team-based healing relationships is one of 8 key drivers in the transformation to patient-centered health home. Becoming a patient-centered health home means wholesale transformation of practice systems for most primary care organizations. That wholesale transformation ultimately entails a broad assortment of small changes in different aspects of the practice. CPCA's Patient-Centered Health Home Initiative develops the 8 key drivers to help practices move through this transformation in an organized way. These 8 key drivers represent the critical dimensions of patient-centered health home transformation. Each key driver includes multiple smaller actions and steps that describe the general directions for the change. As a key driver, continuous and team-based healing relationships has 4 core elements. They are to define roles and distribute tasks among care team members to reflect the skills, abilities, and credentials of those team members, to establish and provide organizational support for care delivery teams that are accountable for the patient population or panel, to assure that patients are able to see their providers or care team whenever possible, and to link patients to a care team so both the patients and the care team recognize each other as partners in care. All of these change concepts link directly to NCQA Patient-Centered Medical Home Certification, specifically Standard 1, Elements D and G. In today's webinar, we'll be focusing primarily on care team development, Standard 1, Element G of PCMH. Developing and optimizing your care teams allows your practice to acquire the points for Standard 1, Element G, a step in ultimately achieving NCQA Patient-Centered Medical Home recognition. But more importantly than that, optimized care teams are a key component of transforming the landscape of healthcare as we know it. The benefits are far more expansive than simply PCMH recognition. Care team development is one spoke in the wheel of attaining comprehensive, continuous team-based healing relationships. There's good reason team-based care is a key driver for patient-centered health home transformation. Patients like being able to see their care team when they need to. Not only does it increase positive experience in patients, optimized care teams are also proven to improve health outcomes. In fact, a 2006 evidence review of diabetes interventions found that providing team-based care was the single most effective intervention in improving intermediate diabetes outcomes. Staff also benefit. Providers get to see their own patients in a timely manner, reducing duplicative care and increasing their effectiveness and their overall job satisfaction. Clinical support staff, such as RNs and medical assistants, get to practice at their highest ability, leading to increased job satisfaction and ownership of the care that they help provide. Staff who work in practices that have optimized care teams consistently cite a decrease in daily chaos and stress. Practices with optimized care teams report higher staff satisfaction and a lower turnover rate. The agency reaps the benefits in the form of decreased recruiting and training costs, decreased patient complaints, and a more positive image in the community. Speaking of the community, they become healthier as a result of care team optimization. A hallmark of optimized care teams is effective patient management and coordination of care. This results in decreased emergency room rates and hospitalizations, which means healthier community members and less costly, uncompensated care being passed on to community taxpayers. Key health outcome measures also improve with care team optimization, as we mentioned before, and I think this is a goal we can all agree is worthwhile. So now you know what a care team is, who belongs on the care team, and why care teams are a worthwhile endeavor. I'd like to move our conversation into the concrete elements of care team development and optimization. Where can you start today as a practice to build your optimal care team? I'm going to discuss 4 primary components that provide the foundation for optimized care teams. They are to understand demand and supply for the care team members, to streamline and standardize key workflows, to create a communication infrastructure for those care teams, and to elevate all care team members to their highest ability. These cornerstone concepts, as I like to call them, each have a tangible application and can provide a roadmap for your practice. They're critical elements in care team optimization, so we'll be spending some time describing each concept and exploring its practical application in the primary care practice setting. In order to have a fully optimized care team, it's critically important that you understand both the supply and demand for your care team members. For those of you who've done work around access in your practice, you'll remember the importance of striking a balance between the demand for appointments and the supply of available appointments. Supply and demand as it relates to care team members is a little different. In this circumstance, equilibrium isn't necessarily the goal. And in fact, in most settings, the care team will be most effective if support staff outnumber clinician staff. What's important here is understanding and tracking both the supply and demand for your care team members. You can do this by creating a department profile. You're comparing clinician FTE to support staff FTE, ending up with a staffing ratio. Because clinicians are our most expensive resource, you can think of them as the demand and the support staff as the supply. What the department profile can help you do is assess whether or not you have enough support staff supply to meet your clinician demand. Now, the question everyone asks is, well, what's the correct ratio? And I'm sorry to say that there isn't really one ratio that fits all practices. However, by measuring where you are now and tracking on it as you make changes, you can close in on what the best ratio is for you. The second cornerstone concept is to streamline and standardize key workflows. In primary care, we have a lot of bulky, cumbersome workflow processes, which leads to staff working harder without benefit because the patients still wait longer. This is a workflow chart that I borrowed from Catherine Tantow, who's an international presenter and expert on redesigning systems for optimal patient access. I'm showing it to you today because it's a map of what happens when a patient calls to make an appointment at a certain practice. We have a knack in healthcare for overcomplicating systems, and the intentions are almost always good. We're trying to prevent mistakes. We're trying to protect the provider. We're trying to get the right care at the right time in the right place for the patient. But what if we stepped away from all of this and streamlined this workflow? What if the patient called for an appointment and was simply given one? This makes great sense for access, but how do you apply this concept to care teams? Optimizing your care team is all about getting the right people to do the right work in the most efficient manner possible. The best way to accomplish this is to standardize work whenever possible. Knowing where to start can be hard, so start with making you crazy today. Is it prescription refills? Is it getting lab results into the chart? Is it phone messages? Choose one and flowchart the current process. Resist the urge to fix as you go. Just record the process as it happens today, warts and all. And it's best if you have your entire care team sitting down together to do this, because you're really likely to find things that not everyone knows about a process, or even more likely, discrepancies between how the process is being executed by different people. Using Post-it notes and a big piece of butcher paper works really well here because you can rearrange them and adjust them as you go through the flow mapping process. So now you have your crazy-making process committed to paper. You can start to analyze it now. Oftentimes you'll discover obvious redundancies that you can just eliminate, or steps that are relics from the past. They no longer serve a purpose. Get rid of those. What you'll have left over is a less convoluted, but probably still not ideal process. So your next step is to map out your perfect world process as a team. Dream big here. If you didn't have infrastructure limitations, or staffing shortages, or cash flow concerns, what would the ideal process look like? Keep in mind efficiency, quality, and relevance. The point of this step of freeing your mind from the restraints is that very often what we assume isn't possible really is. Perhaps you're short an MA, but in your idealized process, you show that by adding an MA, you'll save valuable provider time, allowing for more visits and more productivity. So you're able to then hire the MA. So now you can take your ideal process and modify it to only the true constraints, things like compliance and regulations or building codes. Now put it out to test. Before the team jumps to wide-scale implementation, ask one medical assistant or one care team to try out your new workflow for just half a day. You'll likely find that you need to make some minor adjustments and test again. The third cornerstone concept is building an infrastructure that supports care team communication. It's not enough to just tell people to communicate, or even to provide training on effective communication. You have to additionally build communication into the workflow. It has to become a reflex for staff. One of the most effective ways to do this in primary care settings is with huddles. When it comes to efficiency and teamwork, football players, yes, football players, offer healthcare providers a valuable lesson. A quick huddle can ensure that everyone is on the same page. Daily huddles can help address a number of critical issues. Huddles allow the practice to plan for changes in the daily workflow, to manage crises before they arise, and to make adjustments that improve patients' access and staff members' quality of life. Huddles work because they demand rapid team formation and preparation at the practice level. And perhaps best of all, huddles can become part of a practice's routine almost overnight. Consider this scenario. It's Monday morning at Jane Doe practice, and the phones are already ringing. The doctors and the staff members know the day will be busy, so they all focus their energy on starting to see patients right away. Although this strategy saves time up front, bottlenecks develop within an hour. A lab report is missing. One patient needs an interpreter. 2 physicals are scheduled back-to-back, and the physician needs to leave early for a meeting. By lunchtime, the entire staff is frazzled and running behind. Sound familiar? It's a scene that's been playing repeatedly at primary care practices across the nation. But there is a solution. Huddles have been proven to significantly decrease this chaos. Huddles have helped to eliminate confusion about provider availability for scheduling, lack of awareness of broken equipment or unavailable labs, lack of preparation for scheduled patients who require extra time and assistance, staff shortages due to illness, vacations, and family emergencies, chaos due to last-minute schedule changes, whether caused by patients, providers, office systems, or external factors, and lack of awareness of how each person contributes to the practice's smooth functioning. Huddles can benefit practices of any size. In large practices that use multiple hallways or pods, someone from each hallway can attend a huddle and take important information back to his or her area. In smaller solo practices, huddles prevent problems that can arise when one person assumes that everyone else in the office knows what's going on. So how do you huddle? To conduct a huddle, the care team assembles at a predetermined time every day to look ahead at the schedule and anticipate the needs of the patients coming to the clinic that day. For example, a patient may need a potassium test before he or she meets with the physician. Instead of waiting until the patient is in the exam room with the physician, staff can send the patient to the lab immediately after checking in. Then the clinic staff can adjust the schedule because they know that patient won't be using the original appointment, but will need a slot 30 to 45 minutes later when the test is conducted. Start huddles with a small bit of work and grow the team and the work as you gain proficiency. For example, in your huddle, teams can discuss what patients are on the schedule that are unlikely to show up for their appointments. What equipment will be needed in the room for each appointment? Are the labs that you need in the charge? What additional services can the care team provide for the patient that day that would make a revisit less likely? To make huddles happen in your practice, keep the following tips in mind. Get physician buy-in. Regardless of whether the physician attends the meeting, his or her support of daily huddles is really critical to their success. Settle on a time to meet consistently. It's important that the huddle time become part of everyone's daily routine, not just something that happens when you have time, because then it won't happen. It might take some experimenting to figure out what the right time should be. If the first time that you pick doesn't seem to be working, don't give up. Try another time a day. Early morning huddles have worked well for many practices, but some groups actually prefer to meet at lunch or late in the afternoon. Do what works for you. Experiment with different participants. The best huddles won't necessarily involve everyone in the practice. At some practices, the physicians attend, and in other practices, the medical assistant or the RN attends and then reports back to the physician. I recommend trying to have all key team members present, but if that means there won't be a huddle, try other configurations. Limit huddles to 7 minutes or less. This keeps the meeting focused and prevents team members from becoming long-winded. Hold the huddle in a central location if you can. For example, you might simply gather in the hallway outside the nurse's station. Have everyone stand the entire time. This seems a little silly, but this helps keep the meeting short and focused so you can get back to seeing your patients. There's 2 additional guidelines that sometimes you can disregard after a few weeks if your huddles really start humming. The first one is to designate a huddle leader and put together a structured agenda. Usually, the huddle will run itself after a few weeks of doing this. Additionally, you can identify a huddle champion who can provide daily discipline. It's usually best if this champion is a physician or an office manager, someone with authority. Once the huddles gain momentum, the benefits become self-evident, and generally no extra effort is really required. In most practices, I would say this often happens anywhere between 2 days and 2 weeks. Let's talk a little bit about huddle agendas. Having an agenda when you first start huddling will really help you ensure that the process is meaningful. But what do you put on this agenda? You want to remain focused and concise while still allowing for staff to raise questions and to deal with the unexpected. Here are some suggestions for huddle agenda items to get your practice started with huddles. Check for patients on the schedule who may require more time and assistance due to age, disability, personality, or language barriers. Who can help? What are your resources for the day? Check for back-to-back lengthy appointments, such as physicals. How can they be worked around to prevent backlog? How can you maximize your time? Check for openings that can be filled or chronic no-shows that can be anticipated. Any special instructions for the scheduler? Check provider and staff schedules. Does anyone have to leave early today for a meeting or a web call? Those are important things to know to make the day run smooth. And you can also ask whether lab results, test results, and notes from other physicians are ready in the patient's chart so that when the provider goes into the room, they have what they need to be efficient. Just as huddles are critical on the football field, huddles within your practice can play an important role. A quick, efficient meeting of the minds galvanizes practice-level thinking. The results? Big wins for both you and your practice and your patients. Huddles may form the foundation for communication within the care team, but they're not the only tool at your disposal. In fact, you'll find that most practices could benefit from a more well-rounded communication strategy. Huddles generally can't replace the more traditional hour-long meetings, rather they supplement it. A longer team meeting, monthly or quarterly, is needed to really dig into difficult issues. It's also important that you have mechanisms to communicate throughout the day. Instant messaging can be a great tool and is often available for free download. One popular IM tool is called Spark. It's a Windows-compatible IM program. I've included a link in the references for a free download at the end. Some practices have adopted walkie-talkies or small radio communicators and had great success that way. Beyond daily communication, it's also important to adopt a culture that values communication overall. You can create a clinic newsletter or utilize extranet banners to keep staff up to speed on the goings-on of the health center. Teams generally function best, and care is delivered most efficiently when team members function at the maximum of their licensure, skill set, and abilities. Team members need to recognize the roles that others play on the team can and do. Medical assistants in particular can play major roles in critical functions like population management and self-management support. Practices with limited resources can assess the strengths, interests, and skills of their medical assistants and match them with the practice's needs. This brings us to our fourth cornerstone concept, which is elevating all the care team members to their highest ability. Maximizing staff roles requires a clear understanding of the needs of the clinic and patient demands so that the work and the care team members can be matched appropriately. It also requires the creation and use of clear job descriptions with specific competencies outlined and possibly some additional training or refresher courses. To start the process, you really need to analyze who is doing what today. A fun and effective way to do this is with a game. It's called the Jelly Bean game. And this is a great activity to do at a care team meeting. You might be surprised at who does what, who's replicating work someone else is doing, and what variation between understanding of who is tasked with what. It's a simple game. You need some cups labeled with different job roles, such as provider, nurse, medical assistant, front desk. You get the idea. You need a list of tasks that you're interested in evaluating. Things like who faxes refill authorizations, who calls patients to remind them of their appointment, who completes routine A1C testing on diabetic patients. Each member of the care team needs a bag of jelly beans, or really anything similar, dry beans, pennies, even paper clips. As you read each task, have the team members allocate 10 beans to the cup they believe does the task. If they think it's a combination of people, divide up their beans accordingly amongst the cups. When you get to the end of the list, whose cup is the fullest? In a practice that has not yet elevated the role of their support staff, it is usually the provider. The results are often quite visually striking and can lead to a fruitful discussion amongst the team. In addition to or in place of the Jelly Bean activity, you could opt to use a simple table to analyze current tasks. I would recommend having all care team members complete this tool. It'll help you ferret out those discrepancies and double work, and I would also suggest compiling the results and sharing them back with the team to build buy-in and energy around care team optimization. There's a supplemental document that goes along with this webinar that outlines the Jelly Bean game and also provides a list of common tasks. That'll be a good starting point for you and your team. As you begin to move tasks away from the provider, the bottleneck of the work will start to unclog. Staff will get happier working at their maximum potential, and patients will really have shorter waits. A wonderful resource to get started on elevating some of your most valuable staff resources can be found on the Safety Net Medical Home Initiative's website. The implementation guide you see on this slide contains links to an entire curriculum for MA training. I've included the link in the references at the end of the presentation. I hope that it's clear that the benefits of care teams are many, and that redesigning care team roles is one step your practice should take on the road to full care team optimization. But when the rubber hits the road, how do you actually do it? How do you elevate those roles? We're going to cover 10 implementation tips identified by the Safety Net Medical Home Initiative. Everything I'm about to cover is contained in the Safety Net Medical Home Initiative Implementation Supplement Guide on Continuous and Team-Based Healing Relationships. That's a mouthful. A link to that guide is provided in the references at the end of this presentation. And I personally recommend that you download a copy of the guide and refer back to it as you go through this work in your own practice. The SMART strategies we're going to talk about are to secure executive commitment, choose project leadership wisely, to proactively address staff concerns, to understand regulations, to build a culture of curiosity, to ensure formal and ongoing evaluation, unpeeling the onion, planning for spread and sustainability, involving and informing patients, and celebrating success. There are a lot of wins for taking a hard look at redesigning staff roles to maximize the contribution of every member of the team. Reduction in staff turnover due to improved work satisfaction and role clarity is one. Improvement in clinical flow and increase in performance of preventative and chronic care processes are others. But before these outcomes can be realized, senior leaders must make a commitment to tackling this work. Taking on issues of job descriptions can be messy. Some staff are committed to continuing the work that they've been doing, regardless of whether or not it's effective. They may not be interested in the changes proposed. Others may feel uncomfortable with the new tasks they've been asked to do and need additional training. Some providers may bristle at management interference in standardizing the roles of clinical and operational staff. The key to all of this is having a functional leadership team that recognizes these barriers to change and that can address concerns when they inevitably arise. Choosing change leaders. There are several ways to organize a quality improvement redesign effort. One is to work through existing management infrastructure, tasking line managers to work with their staff to redesign roles. Another is to convene an improvement team with representatives from different groups across the organization. It might be helpful to start your first attempt at tackling team roles with this more visible interdisciplinary effort. But success requires more than just selecting good team members. Leadership needs to support these members as they do their work. For example, clinic managers or assistant medical directors who lead sites must be well informed about the work of the group. So if someone from their improvement team is presenting a change, these leaders are able to back them very actively. To support consistent messaging, the improvement team members can use written talking points or speak from notes, and leadership can and should celebrate openly, thanking the improvement team for their work. Most importantly, make sure the clinic managers know their job is to support the improvement team back at the site, and if need be, to step into the line of fire with them. Effective change leaders could be hiding in many different places within the practice. Title and supervisory status is much less important than personality and work style. Neighbor Care Health, a large FQHC network of clinics in the Seattle area, has done extensive work on their care team model and have identified the following characteristics of good change leaders. Not all candidates have to have every one of these characteristics, but this is a useful evaluation tool to use when identifying potential change leaders in your own organization. Leaders have to be honest about their motivation for redesigning roles. If it's about funding cuts, leaders need to be honest about that. If it's about turnover, show everyone the data. There must be support for people to be confident in their new roles. Though some staff may feel relieved to be working in new and more advanced roles, others may feel nervous about their ability to perform, and others may be worried about their colleagues' ability to perform. Data can help address hesitancy from staff about sharing roles and tasks. Observe staff as they work and pull raw data. For example, in one practice, blood pressure was being taken 2 or 3 times per visit because the nurse and provider were retaking it, not trusting the results of the medical assistant. Either because of lack of training or simply a lack of confidence, waste and rework can get built into practice operations. Taking these things seriously means providing ongoing assessments, trainings, and guidance for tasks to be performed. The organization should also conduct assessments on all staff, regardless of tenure, to identify areas where training might be beneficial, and then work with internal staff to provide mentorship. For broader clinical issues, like how to take blood pressure reliably or perform an EKG, you might consider partnering with a local medical assistant training program to conduct clinical refreshers. It's critical for a practice to understand the legal limits within which different team members can work. A compliance officer, or someone with a firm understanding of healthcare regulations and laws in California, will play an important role in redesigning staff roles to optimize your care teams. At the end of the slide deck, I've included a page which has a list of valuable references, all on scope of practice. An early and essential component of redesigning team roles is understanding the volume and variety of work staff currently do. When staff start to take an objective look at the type of work they spend most of their day doing, surprises can arise. Fostering a sense of curiosity about, say, why are so many faxes coming in for the same prescription, or how much time is spent triaging, rather than addressing a patient's phone questions, can be key in uncovering and addressing major sources of wasted effort. Often, when frontline staff start to look at simple data, big changes can result. Fostering a culture of curiosity helps the practice move away from, because we've always done it this way, to, what if we tried something different? This approach isn't always easy. It means allowing frontline staff to ask questions, to take their questions seriously, and to follow up on them. But the payoffs are big. Redefining the roles of staff is not a static process, but one that evolves. Especially at the beginning, staff should have a way to capture tasks and activities that they perform that aren't explicitly included in their new role. By creating a formal mechanism to record these outlined tasks and a process to reevaluate how things are working, staff are less likely to be drawn back into old patterns and roles. And essential functions that may have been overlooked can be formally evaluated to see who is best positioned to address them in the future. Having a formal process for reevaluation also means that the changes you worked hard to implement can be held constant for a while before changing again. This can lower staff anxiety and give everyone a chance to get used to the new changes before diving back in again. At some organizations, they wait to make changes to any standard new work until all clinical teams have been trained and have used the new templates for a given period of time. This enables everyone to give feedback on what works and what doesn't before updating a tool. Examining any one team member's role invariably forces questions about how other team members work. For example, the front desk staff has a role in customer service, referral management, care coordination, scheduling, call management, prescription refills, phone consultations, and financial collections, among about everything else. Trying to get clarity about the front desk role in any of these areas forces questions about how registered nurses, medical assistants, providers, and all the other care team members work. Ultimately, there is no way to redesign just one team role, but you don't have to address them all at once, and in fact, you probably shouldn't. But you can't leave related roles hanging for too long either. So where do you start? It may make the most sense to start where there's a burning platform. In many cases, this may be a place where there's high staff turnover or where staff are seriously underutilized. When nurses start to joke that they're fax jockeys, you know it's time to look at their work. One approach is to start by looking at a single role and by peeling off the inevitable questions that arise about closely related roles and charging a separate group to address those. For example, tackle the role of the RN and then deputize a related team to examine the medical assistant role if and when questions arise. Other more discrete roles like front desk staff, lab personnel can then be looked at in sequence. Too often, we think about all the hard work of designing and implementing a new change and focus very little on what it'll take to spread and sustain the change over time. In the case of team role redesign, there is tremendous inertia for returning to the old ways of working. Without a serious plan for embedding change, it's unlikely to be sustained. What does it mean to embed change? There are some important considerations in ensuring that a desired change sticks. You need to make the changes explicit. The changes need to be recorded in job descriptions, in tasking guidelines, in scripts, in protocols. Once that change is documented, it's absolutely critical that you communicate that change to everyone. The fastest way to defeat change is to fail to communicate it. Many positive changes fall victim to attrition. They gradually peter out. To mitigate this, put a measurement system into place. You need to monitor outcomes over time. When you start to see decreases in staff satisfaction or declines in clinical or operational process measurements, you know it's time to revisit roles. Some health centers use a staff survey to assess how folks feel about providing patient-centered care and what they think could be improved. This is a really simple measurement mechanism that you can put in place to help hold the gains. You need to provide ongoing training. Turnover and new staff demands that a formal system for ongoing training and mentorship is in place. Without this, the new nurse that you just hired from the clinic 3 towns over, who is just doing phone triage at Clinic X, may not be prepared for her enhanced role within the care team at your site. Focus on local leaders. For changes to be sustainable, they must become embedded in the daily operations of the practice. Most often, when changes don't take, it's because local leadership doesn't have the resources, the expertise, or the inclination to support the new way of working. It's essential to keep priorities clear and find ways to help your internal leaders continue to monitor and adjust roles. It's also important to involve and inform patients. Helping patients understand the new roles of the care team greatly improve the ability of the team to function in those new roles. Here's an example. One practice redesigned their phone system to route clinical calls directly to the care team. Sounds like a great idea, but patients were surprised to be asked for their patient ID number. They were often unprepared to be connected directly with the physician or the nurse. They weren't expecting it. So after a multi-modality approach to communicating the change to the patients, through formal newsletters, materials at the front desk, reinforcement by the care team members in person, patients finally learned to have their ID number on hand, resulting in fewer dropped calls and higher satisfaction. If you can communicate the change on the front end, you can avoid those problems altogether. Does your practice have a patient advisory group or committee? Ask them what they think about the care teams. What's important to them about their relationship with care team members and the whens, hows, wheres of their care? Don't forget that one of the primary objectives of care teams is to become patient-centered. If we leave patients out of the planning process and fail to communicate change to them, then we've failed at this very basic objective. Involving and informing patients about the structural changes of the care team isn't enough, though. Optimized care teams embrace effective communication and take time to train all staff. Finally, we all know that change is hard. Changes like this impact the culture of an organization, but the returns on these investments can be remarkable. Remember to celebrate success, even the small ones. Celebrations can include bringing in snacks to the office, having leaders push a coffee cart around, or even drawings for gift cards. The celebration doesn't have to cost a lot of money, but recognizing people's hard work is important. People who choose a career in healthcare are often motivated by helping others. By optimizing the staff roles supported through training, staff satisfaction and motivation can and will improve. I would be remiss if I didn't discuss team culture during our webinar on optimized care teams. Teams are dysfunctional simply because they're made up of people, and people are imperfect. But we can learn how to recognize and cope with these common and natural dysfunctions. Many of you may be familiar with the 2002 business book written by Patrick Lencioni, The 5 Dysfunctions of Teams. The book, written in fable form, reveals the 5 dysfunctions which go to the very heart of why teams often struggle. It also outlines a powerful model and actionable steps that can be used to overcome these common hurdles and build a cohesive, effective team. I recommend it for any leaders working with teams in healthcare settings or otherwise. The first team dysfunction is the absence of trust among team members. This is when individuals feel they need to be or should be so strong, so right, so confident that they reveal no vulnerability. For a team to be functional, everyone has to learn to trust the other people on the team to not exploit their vulnerabilities. I have found that in the care team setting, physicians, especially those who've been at the helm for a long time, may have a very hard time admitting when they don't know how to do something, and so have difficulty asking for help. This speaks to a fear of being vulnerable. One might tell themselves, if I don't know how to do everything, then I'll be exposed as a fraud or as an incompetent. This isn't true. No one can be expected to know everything about everything, including physicians. The best teams are comprised of members who take the time to know each other well and who are utterly honest with each other about each person's strengths and weaknesses. That's how a team, in its work together, avoids depending on the wrong person to get a specific job done. You may know that Jane is not good at group communication, so everyone jokes about that, and Jane's not put into the position unless she says, well, I really need to overcome this fear and I'd like to do the group thing. Can you help me? One safe way to guarantee vulnerability is to recognize your own strengths and weaknesses and describe them to your teammates. Yikes. Modeling this behavior might be hard, but it will result in a more trusting team environment over time. The second dysfunction of teams is our innate fear of conflict. Because of this, we create artificial harmony. I know that I'm guilty of this. I learned to be nice to everyone so everyone would like me. I don't know where, why, or how I learned to do this, but I know that I can unlearn it. Let me illustrate how this dysfunction works. 3 of my staff members and I teamed up recently to redesign a workflow for a clinic service that we were planning to expand. This imperfection in myself, the fear of conflict, reared its ugly head during this process. I was working closely with a colleague who was unresponsive and fairly unfriendly. I knew I wasn't doing the redesign work to make friends, but on some level, I just wanted her to like me. And it's true that most people will do a lot for their friends, but it's also true that people really respond to those whom they respect, whether or not they like them. So instead of trying to get this woman to respect me, I tried to make her like me. And well, she didn't like me and she didn't want to like me. My quandary hurt my team because I was unable to get her to do the things we needed her to do. I did not directly confront her lack of cooperation. That would have upset the established harmony, which was really artificial harmony I had created. Among healthcare teams, this is the most dangerous dysfunction of all. The stakes are high, patient safety and health. Although it is uncomfortable at times, conflict is necessary for healthy teams, and the more you do it, the more you appreciate how constructive conflict can be. The third dysfunction is the lack of commitment to the decisions of the team, which means that people are ambiguous about achieving something together. This is related to the previous dysfunction, in that it requires everyone to err for thoughts and feelings regarding an idea or course of action so that the best decision can be made. This is not as much about democracy as it is about getting everything in the open and on the table. In an optimized care team, all team members are actively engaged in team dialogue to reach a decision. All team members commit wholeheartedly to the decision. No one is on the sidelines watching to see how things come out. The important thing is that everyone on the team commit to the decision and do his or her part to make it successful. Hard feelings usually spring from not airing all your concerns in the first place, or feeling like you weren't heard. So as a team member, you have the responsibility to air all of your concerns and also to listen thoughtfully and completely to your teammates' concerns. IDEO, the world-renowned Silicon Valley design firm, does this beautifully. The whole team looks at a problem, and all team members throw their thoughts into the mix. There's really no individual ownership or feeling of my idea has to win, or I'm right. In fact, because the team really mixes it up and dissects, reconstructs, alters, and embellishes ideas, a great team produces ideas that are clearly a product of team thinking and are far superior to the thinking of a lone genius. This is really how the best ideas emerge. The fourth dysfunction is avoidance of accountability. This sounds like, I'll do my best. I'll get to it if I have time. Or, sorry, but the dog ate my homework. A team member never, ever lets the team down with respect to meeting deadlines and doing quality work. If a team member does either, it's the responsibility of each and every other team member to immediately confront the errant colleague. Not doing so fosters low standards for people in the organization. Remember, inaction is an action. You must hold your peers responsible for achieving results and working to a very high standard of quality. It's also your responsibility as a team member to give permission to your teammates to hold you accountable. One important aspect of all of this is that you must trust that the team member has good intentions in holding you accountable. So it's not a personal attack that calls for defensiveness, but a moment of insightfulness about your own shortcomings. And you, when holding another member accountable, need to trust that your teammate was merely falling down on his commitments and not trying to sabotage the project or the project team. This circles us all the way back around to the very first dysfunction, absence of trust. Now, for the final dysfunction, the ultimate dysfunction, inattention to results. This is when our egos get in the way of our team's ability to be successful. Lenciani uses an example of a basketball team. If there's one star player who's concerned more with how many points she scores rather than if the team wins or loses, then the team is hurt by her, not helped. We have to learn that our biggest organizational successes usually come from team successes rather than individual successes. Egos exert themselves in both big and swaggering ways and small, it's all about me ways. The team that's the victim of this dysfunction will likely die from 1,000 small ego cuts rather than from having an egomaniac on the team. Becoming a tight and effective team is astoundingly rewarding. The work that gets accomplished through teams is profoundly better. It's not all a cakewalk. Avoiding the pitfalls of teamwork takes diligence and dedication, but a team working together towards a common goal is able to produce remarkable results. So, as you develop and optimize your care teams, remember the 4 cornerstone concepts which provide a foundation while keeping an eye out for the team dysfunctions which can threaten to knock your team off the structure. In conclusion, I'd like to remind everyone of the main areas we've covered today. We've defined care teams and discussed how they fit into the bigger picture of patient-centered health home. We've talked about the 4 cornerstone concepts of care team optimization. We've reviewed 10 smart strategies practices can use specifically in the redesign of care team roles. And we've discussed the common challenges of team culture. On the path to patient-centered health home transformation, there are many steps. Care team development is just one of them. I hope today's learning module has given you insights into how care teams fit into this bigger goal, tangible tools to help you get there, and some resources to take away and share with the rest of your practice. Thank you so much for your time, and if you'll review the next few slides, they're all the references and resources that I mentioned throughout the webinar today.
Hi, Sarah. I'm back.